Good afternoon. I was a resident at Mass General, and I'm now in New York City, but every time I come back and hear all your stories and all the wonderful work that is being done here, it is just such a privilege to come back to Boston and recognize what a special medical community it is here. So thank you for having me back. So the question that I want us to think about today is, what is the difference between 20 and 24 million? Now, those are both estimates on the number of people that might lose health insurance if the Affordable Care Act is repealed. One way to answer the question is simple. It's 4 million, and that is a huge number. It means that potentially 4 million people's lives hang in the balance. Another way to answer the question is zero. There is no difference between 20 and 24 million, just as there's no difference between 10 and 20 and 30 million. And I say that because those numbers are too large. They're too abstract for our minds to meaningfully grasp. That's not how people think. That's not how they reason. That's certainly not what moves them to action on the behalf of others. And so on a policy level, on a political level, on a public health level, there's very little difference in the motivational force, the kind of impetus for people to do something new, to behave differently between 20 and 24 million. So you might say that the mathematical delta between 20 and 24 is 4, but the motivational delta is close to 0. And so today I want to argue that the truth lies somewhere in between these two answers. The truth is somewhere in between the obvious, the straightforward answer of 4 million, and the less obvious, the more provocative answer of 0. Because numbers are important, but numbers are just numbers until we give them life. They have to be put in the right context for them to have real-world impact. We have to know, we have to feel the lives of the people that are affected by these programs, that are affected by these policies. And that might seem like an obvious point, and that's because it is. There's nothing new, there's nothing novel about what I'm saying. The idea that stories can be used to create change is one of the most ancient insights that we have, but I don't think that we in healthcare use it effectively enough. We can do a better job of reaching people, whether they're patients or clinicians, policymakers, funders, in new and interesting and more compelling ways. So whatever your views are on the last presidential election, I think what's obvious is that people didn't necessarily vote based on policy or based on facts or based on character or temperament. People bought into a particular narrative, a particular story about what was going on in the world around them, and that is ultimately what carried the day. And so we can use that insight as well. We can use stories to reach people in more compelling ways and to try to change towards a more just healthcare system. So when I talk about narrative, I'm really talking about two different forms of narrative. And the first is the use of human stories. So those are our stories, those are patient stories, those are family stories. It's the story of a patient I saw a few years ago, the story of a man who struggled his entire adult life with bipolar disorder. And his illness dominated our years together as doctor and patient. He, on more than one occasion, had tried to take his life with a handful of pills. He had driven his car into a tree. And so we worked closely with his psychiatrist to adjust his medications, fearing that he wouldn't make it through the next attempt. But the reason that his life ended too early was not suicide. It was not an accident. It was something that's far more common, something more mundane, something that's too often overlooked in people with mental illness. It was cardiovascular disease. He had a heart attack. And so those types of human stories, they give insight into the lives of people who are too often left behind. But there's another type of story, and that is the story that we need to put together to describe the larger social context around what's going on with our patients. So it's a story that tries to create a larger narrative about who we are as a health system, who we are as a country. What values do we hold dear? How do the lives of clinicians, how do the lives of patients fit into the larger story of progress? And for that, we need data. We need to tell the story of large, persistent, sometimes even growing healthcare disparities for Americans with mental illness. We need to talk about research that suggests that patients with serious mental illness die 15 and sometimes even 30 years younger than those without mental illness. It's a disparity that's larger than for race, ethnicity, geography, socioeconomic status. We need to talk about the fact that people with mental illness who are diagnosed with cancer have death rates that are 2 to 4 times higher for some cancers than people without cancer. We need to talk about people who struggle with mental illness and how they have to deal with homelessness, with poverty, with social isolation. We need to talk about how folks who have schizophrenia, disparities for them in early mortality have been growing over time from the 1970s to the 1980s, the 1990s, all the way until today. And so for me, the notion that you can merge personal story with higher level policy issues is something that has been ingrained in my life from the very beginning. I was not born in the United States. I was born in England. I still can remember the first memories of my life, which were of my baby sister, who was lying inside of an incubator in the ICU, struggling to breathe. She was born at just 26 weeks. My mom went into labor early. And doctors told my parents that if their baby girl survived, she would likely have profound cognitive or physical disabilities. And praying that she wouldn't, my parents named her Karishma, which means miracle in Hindi. Now, this was 1990. My dad was having some trouble finding the type of work that he wanted to do in England. My parents considered moving back to India, but thought that the medical care there would be suboptimal. But more importantly, that the social stigma around disability in India would prevent Karishma from realizing her full potential. Now, 1990 was also the year that the United States passed landmark legislation, the Americans with Disabilities Act, which declared that physical and mental disabilities in no way diminish a person's right to fully participate in all aspects of society. And I think that law, that sentiment, played a huge role in my parents' decision to move to the United States. And it has allowed my sister to flourish. So Krishma was diagnosed with cerebral palsy. She uses forearm crutches to get around. But she's never let that get in the way of the things that she wanted to do. So she's been able to ski and horseback ride. She was valedictorian of her high school. She went to an Ivy League school. And today, she practices as a radiation oncologist who cares for other people. So hers is the story of progress. Hers is the story of what can happen when people get the support, the opportunity they need to thrive. And that happens from instituting policies like this. Now, for those of us who care for patients, storytelling is really central to everything that we do on a day-to-day basis. So understanding who a patient is, what they have been through, why they're presenting to care, that is at its heart an act of story gathering and storytelling. We need to take patient data and clinical history and medical evidence and wrap it all together into a story that makes sense to ourselves and makes sense to our patients. But I think what we need to realize is that we have experiences and we have insights that need to be part of a larger public conversation. We need to help others understand the issues that we're grappling with on a day-to-day basis. We need to figure out how we can deliver and receive better care and how we can march towards a more equitable health system. And that happens from putting our experiences and our insights into the public domain. But that is, I recognize, no easy task. It's not easy to talk about health and science. Science, by its very nature, is messy. It's constantly being overturned. It's constantly being updated. And often, new science can look something like this. So everything we eat both causes and prevents cancer. Here we see clearly that coffee and corn and milk and eggs are cancer protective, and they are also cancer causing. On the other side, you see that you need somewhere between 5 and 10 servings of fruits and vegetables every day to live a healthy life, or maybe just kidding, you don't need that at all. One study found that half of new studies that are covered in the newspaper are later overturned or unconfirmable by subsequent meta-analyses. And studies that get more media coverage are more likely to be overturned. And I should note that this study itself got a lot of news coverage, so I'm not sure what it says about the validity of these findings, but suffice it to say, it's hard to talk directly and forcefully about things that have a lot of nuance. Another challenge is that in medicine, we tend to communicate in statistics, but most people tend to think in stories. So in medicine, in science, we try to avoid the use of anecdote, and that is appropriate most of the time. One of the goals of evidence-based medicine is to use evidence and data to drive decision-making and to avoid anecdote to make decisions about diagnostics and treatments. We sometimes think of anecdote as a waste of time, comparing it to our more powerful facts, studies, and statistics. But I do think there's an important distinction that we should make between the use of anecdote to justify a particular policy position and the use of anecdote to explain or to promote a policy position that is already rooted in data. So you don't want to use a collection of anecdotes to make policy, but you might want to use a collection of anecdotes to advocate or to promote a policy that is already rooted in data. And it's important not to get those two things confused. Now, a third issue is that in healthcare, we use a very nuanced and cautious type of language. So on the left, we see the language of science. The patient asks, does it work? The response is, that depends on what you mean by does, it, and work. The language of advocacy is far more direct. These guys, as you can see, they're not mincing words. They're determined to take something down. What that something is, we'll find out later. So scientific language is nuanced, scientific language is cautious, and again, that is appropriate most of the time, but sometimes we need to step out of that and be more direct in the way that we're communicating with people. But I think the biggest issue is that even on issues of established science, there can be a huge gulf between what science knows and what the general public believes. So almost all scientists believe that humans have evolved over time, but only 2/3 of US adults feel the same way. Nearly 90% of scientists think that all children should be vaccinated. Again, Around 2/3 of the general population does. 90% of scientists believe that humans contribute to global climate change. And again, only half of US adults think the same. The list goes on and on. And there are probably any number of reasons that you see these types of discrepancies. There are people that profit financially or politically by spreading misinformation. But at least one problem is that scientists don't seem to communicate effectively about their work. So only 31% of Americans, less than a third of Americans, think that scientists are effective communicators. Most science graduate programs don't offer any training in how we should communicate about the knowledge that we produce, how we should talk about the findings that we uncover. And increasingly important domestic programs that are rooted in science are on the chopping block, things like EPA protections, public health insurance expansions, NASA, NIH budgets. So better communication is critical. And when we think about how to use stories to create change, there's a framework that I think can be very effective. It was developed by a professor just down the road at Harvard's Kennedy School, Professor Marshall Ganz. And Professor Ganz was a community organizer for decades. He's really an expert in the use of story and narrative to inspire other people to do something differently. And he thinks that there are three main components to any story that inspires other people. It's the story of self, the story of us, and the story of now. And the framework is rooted in ancient wisdom by this Jewish sage Hillel the Elder in the 1st century, who said that if I am not for myself, who will be for me? That's the story of self. When I am only for myself, what am I? That is the story of us. And if not now, then when? That is the story of now. So the first component is the story of self. That is your own story. It describes why you feel called to this issue. What experiences, what values have led you to this point? The second component is the story of us. That is an attempt to connect your own experiences, your own values, with the experiences and values of the people around you, trying to identify who your people are. What is your collective story? What ideals do you share with the people around you? And the third component is the story of now. And this refers to the challenge that you're trying to address. It has to describe why it's urgent right now. So in 2019, Americans with serious mental illness are up to 4 times more likely to die after receiving a diagnosis of cancer. You have to describe what your motivating vision is for change. What are you recommending that we take action on? And ultimately, why do we need to do it right now? So I'll just close by saying that whether we like it or not, we are now part of a healthcare system that is equal parts medicine and politics and economics. And the current social climate makes it hard not to feel like our duties extend beyond the clinic and beyond the hospital. And that's in part because we as professionals now represent an increasingly rare link in society. Just by virtue of being in this room, we're relatively well off, well connected, well educated. But we also have a unique perspective into some of the most disadvantaged segments of society. We're intimately familiar with what people are going through on the ground. And that's not the case for many professionals. It's not the case that bankers or management consultants are examining the feet of diabetic patients or that they sit next to people who are struggling with opioid addiction. But we do that every day. And so we have to speak up, if only to give voice to people who don't have the opportunity to speak for themselves. And to do that most effectively, we need data, and we need narrative. We need statistics, and we need stories. So tell me about the 24 million people that might lose health insurance, but also tell me about just one. Science, data, statistics, those are the building blocks of progress. They point the way forward. But stories are what move us. They provide the motivational spark. They provide the impetus that compel us to do something differently. They inspire us to take action for ourselves, and they inspire us to take action on the behalf of others. Thank you.